Hello, and welcome to our first keynote of the IDF National Summit, COVID-19, Where We Are and How Do We Approach Winter. For families living with a primary immunodeficiency, the coronavirus pandemic has presented unique challenges, from potentially limited access to medical care and supplies to increased anxiety and stress. What challenges does our community face? What will the lasting impacts be? I am joined today by our presenter, Dr. Kate Sullivan, who will explore the impact the pandemic has had on the PI community, what the greatest challenges have been, and what the new normal will look like and when it may come about. Dr. Sullivan is a world-renowned immunologist who serves as the Division Chief of Allergy Immunology at the Children's Hospital of Philadelphia since 1993, overseeing one of the largest North American clinics for inborn errors of immunity. If you have any questions at all for Dr. Sullivan during the session, please submit your questions via the question box located on the side of your screen. These questions will be answered during the live Q&A session following Dr. Sullivan's presentation. Finally, before we begin, a quick disclaimer. The information that is presented today is not intended to be a substitute for medical advice, diagnosis, or treatment. As always, seek the advice of a physician or other qualified medical professional concerning a medical condition. Do not disregard professional medical advice based on the information presented during today's event. And now, without further ado, I would love to pass it to Dr. Sullivan for her presentation. It is all yours, Dr. Sullivan.
Thank you. Thank you, Ashley, so much, except for the part where you said I was going to predict the future, which I'm actually not going to do. I don't know what the new normal is going to look like, but I am going to try and cover a lot of ground today and talk about quite a few elements regarding COVID-19 that I think people will find important. I hope this information is of use to you. Let me just be sure. Here we go. So the idea is, where are we right now, and hopefully where are we going, but there's no predicting the future here. So this is what I would like to cover. I want to just give you a sense very briefly. I don't want to spend a lot of time talking about the disease so much, but I do think it's helpful to have some context before I talk about what it means for people with immune compromise. I will be talking about treatment and vaccines, and at the end, I'll have a little bit of a path forward for all of us. It's not unique to people living with PI. So first of all, before I get started, I want to just go through some nomenclature because I think it does get a little bit confusing. So SARS-CoV-2 is the name of the virus, and the virus is shown over on the right. You can see these are little viral particles with a halo. That's why they're called coronaviruses. And I've tried to get the word out about June Almeida. So June Almeida discovered coronaviruses, and she was a high school dropout who subsequently went into science and really led a quite remarkable life, and I'm not sure she gets enough credit. Well, SARS-CoV-2 is the virus and COVID-19 is the disease. And so I will use both terms, but just recognize they're referencing sort of two elements of the same thing. So what's it like to get COVID-19? Well, there's a lot of people that are asymptomatic, and I'm going to show you more of a sense of a timeline in a minute, but I want to lay out just a rough overview of the disease and also the way in which doctors categorize people. So people can be asymptomatic, and we know that there are lots of asymptomatic people now. You can have mild disease, so just a cough and a fever, but your x-rays are normal. You certainly don't need the hospital, and those folks get over it relatively easily. There can be somewhat more severe symptoms, so the x-rays are abnormal. You can see sort of a pneumonia in the chest. And then we get to what I'm going to call severe. And so severe encompasses people who need hospitalization, and it actually has a definition that doctors have agreed on, which is sort of miraculous in and of itself. And then critical references people in the ICU. So you can imagine that you can flow from one of these to the other as your disease progresses. And just to give you some sense of the timeline, most people develop symptoms on or around day 5. And they shed virus for 2 days before they have any symptoms for those people who do develop symptoms. And then there's a small number of people who will get worse right away. So over the first couple of days of developing symptoms, they will get sicker and sicker quite quickly. But most of the people you hear about that are hospitalized and in the ICU, that is occurring a week to 2 weeks after the onset of symptoms. So that just gives you a sense of the timeline. And why did I bother to go through it in such detail? It's actually a very unusual timeline. Most respiratory viruses become symptomatic within about 2 days of exposure. So this is already a strange virus. You didn't need me to tell you that. Everyone's been saying it. But just to lay out one more aspect of it that might not be that obvious, but marks this virus as having a very unusual phenotype or picture. So asymptomatic has been in the news a lot, and the reason is that there are a number of publications looking at rates of asymptomatic infection in different populations, and they range from about 1% to 50%. We think the real number, and I'm using air quotes here, the real number is probably closer to 50%, but it does vary depending on the group that you're examining. And so there probably is a broad range, maybe not this broad, but there probably is a range of percentages of people who are asymptomatic depending on the particular population being studied. And it also depends a little bit on how the testing was done. So I'm not going to get into testing because, boy, are those deep waters, very thorny topic. But not all of the tests are equally sensitive or equally specific, which means there can be both false negatives and false positives. So this pyramid is meant to sort of capture the concept that the majority of people are asymptomatic and have mild disease. Now, the numbers that you see here are from the Centers for Disease Control. There certainly is abundant data from the US to support these, but again, these numbers would be a little bit different. I'm a pediatrician. If I tried to put numbers from the pediatric experience, it would be far more weighted towards asymptomatic. If I was a geriatrician and taking care of people over 65 years of age, then there would be a greater weight towards the more severe cases. So the exact numbers are going to vary depending on the patient population, but the concept of a pyramid with only the tip having severe disease, I think is a worthwhile one to remember. Well, the reason I went through all of this was actually to get to this slide, believe it or not. Now, the concept behind this slide is really what I've been talking about, but I think it gives you more of a sense of flow. So you could go from being mild one day to being severe 3 or 4 days later. And the reason that's useful to think about is that the immune system is acting in different ways at different points. So this is a really important concept that's going to be useful about 15 slides from now. So I'm going to go through it in a little bit of detail. So when we are initially infected with this virus, or indeed any virus, the first thing that happens actually has nothing to do with our immune system. So the first thing that happens is the cells that the virus lands on and infects, which are usually the cells that line the nose, the eye, the mouth, the throat, the trachea. Those cells that are just simple lining cells of our respiratory tract are the ones that are infected, and they send out a wave of hormones called type 1 interferons. These type 1 interferons tell the cells next door that there's a virus and they should put up their walls. So you can think of it like a castle keep. So the idea is that the cells next door put up all these defenses to slow the spread of the virus in those lining cells. So there's no white cells involved. There's no antibodies. This is just local containment. And this happens for every viral infection. This turns out to be a big deal early in infection. And the next part that sort of kicks in is T cell activation. So T cells are a type of white cell. They get activated, but they are slow pokes. And so it takes them about 5 to 7 days to really get agitated and to the point where they can kill the virus. So it's not instant gratification. And so this early wave of type 1 interferons that are slowing the virus is critical to buy enough time for the T cells to be able to get activated and initiate their killing sequence. So that's all happening in the mild and moderate disease. When you get to the people that are in the ICU for long periods of time, they got there for a different reason. They got there because their immune system got overactivated, really agitated and in a way started fighting everything and sending out lots of alarm signals because it was behind the 8 ball. And so all of this inflammation is what causes much of the damage for the people that are the sickest. It's actually a completely separate part of the immune system, and it's actually not necessarily part of killing the virus. So let's take that background information and let's talk about what it means for real live living people walking here on the planet. So let's talk about what we know about risks of severe disease. So this group that lands in the ICU, very sick, what do we know about them? Who are these people? So it turns out age still today is the single biggest risk factor for severe disease. So when you see 13x, that's compared to people that are 30 years old that are otherwise perfectly healthy. So 13x. So by far, age is the biggest risk factor for severe disease. Obesity continues to be a very significant risk factor for severe disease. And then I've listed some other things on this slide, including lung disease, which of course is of relevance to people with immune deficiencies. But I put the numbers there so that you can compare them. So having lung disease isn't great. I don't mean to make light of it or to in any way diminish its importance, but it's not nearly as big a risk factor as age and obesity. So I just wanted to give you a sense of the spectrum. Now, something that doesn't get a lot of play in the press, but is clearly relevant for disease severity is the amount of virus that infects you at the time you're infected. So in other words, touching a surface and getting one little virus in your eye is much more likely to be associated with mild disease than someone who gets a face full of cough and it goes right into their trachea. So this is hard to show in people, but it's been demonstrated over and over again in animals, and it's true for many respiratory viruses. So that's why I list it as probable. It's very difficult to demonstrate in people. Well, on this particular webinar, we want to talk about immune compromise. We want to talk about people with immune deficiencies. That's why we're all here today. But I'm going to start by talking about immune compromise. And why is that? Well, we know a lot more about people with secondary immune deficiencies than we do about people with primary immune deficiencies. But let's take some of the lessons from those people because I think they're useful. So when I say secondary immune deficiencies, what do I mean? Well, people on chemotherapy, people with HIV, people on biologics for arthritis or inflammatory bowel disease. Those are secondary immune compromising conditions. A huge surprise to come out is that biologics often used to treat arthritis and inflammatory bowel disease are actually beneficial. So if anyone on this webinar is on a TNF inhibitor, the best data demonstrate that TNF inhibitors are protective for severe disease. And that was a huge surprise. You would never have predicted that. There's one exception, and that's a particular type of cancer therapy called a checkpoint inhibitor. These drugs are meant to kick the immune system up to try and drive the immune system to help get rid of cancer. Those drugs are associated with more severe disease. Do you get the pattern here? So remember, the folks in the ICU are the ones that have immune overdrive. And so drugs that do that or settings that ramp that up are more likely to be associated with severe disease. And a hugely surprising thing is that HIV is not associated with increased risk of severe disease. And again, AIDS and HIV has long been associated with more severe disease for many infections. So a huge surprise that COVID-19 was not more severe. Well, we're here today to talk about primary immune deficiency. So there are some lessons from those immune compromising conditions. I think the message to take away is that there's something quite peculiar about this virus. Conditions where we normally expect people to have an increased risk of severe disease. It's not necessarily true for this virus, so big surprises. Well, let's talk about primary immune deficiencies, and I'm going to give you the punchline first. And the punchline is that antibody defects do not seem to be associated with an increased risk of severe disease. What a surprise, right? Additionally, mild T-cell defects do not seem to be associated with an increased risk of severe disease. Now, that's perhaps less of a surprise because we already knew about the data from HIV and AIDS, but still, I think a lot of immunologists were sort of rocked on their heels. Now, for people with chronic granulomatous disease, I would say the jury is still out. I'm not sure we have enough data to say what the risk is there. So now that you've had the punchline, because I think that will probably surprise many of you, just like it surprised immunologists, I'm going to share with you a little bit more granular detail. So the data that I'm going to share with you come from 2 studies. I was a part of an international collaborative study to collect data on patients with immune deficiencies, and that included ultimately 94 patients. And then Charlotte Cunningham Rundles reported a study of 16 patients from New York City. So all of the patients who died had something that put them in a high-risk category besides being immune deficient. So that's why I went through that risk list at the beginning. So all of the patients who died had something besides their immune deficiency that put them at risk. Interesting, autoinflammatory diseases were not a risk for severe disease. And also, surprisingly, 2 patients with common variable developed antibodies to the virus. Now, we have known for a long time that people with common variables sometimes retain some antibody producing ability. We've seen people respond in part to the pneumococcal vaccine, in part to the influenza vaccine. So maybe not totally surprising, but still how amazing to see it in real life. I think it's also worth talking about who were the cases that were mild. Who were those people? So among the group that was asymptomatic, there were patients with autoimmune lymphoproliferative syndrome, interferonopathies, particular immune deficiency called STAT1 gain of function, Wiskott-Aldrich syndrome, chronic granulomatous disease, X-linked A gamma globulinemia, and various forms of combined immune deficiency. Now, many of you will not recognize all of those terms, but suffice it to say that this covers a lot of territory in the land of primary immune deficiencies. There's no theme here. It's not that these are all alike in any particular way. Similarly, for the mild cases that were treated as outpatients, it's the whole gamut, the whole spectrum of all 430 different primary immune deficiencies are in these 2 groups. And what a surprise is that? We had all predicted that maybe some immune deficiencies wouldn't be at risk, but some would. And so this information came as a huge surprise to immunologists around the world. Now, I'm going to share with you some data that's going to sound opposite of what I just told you, but probably isn't. It's just a different way of asking the question. So we, in the world of immunology, asked our patients to tell us if they came down with COVID-19, and we reported those to a registry. So that's the data that I just shared with you. A very enterprising group in New York, France, and Italy turned the question on its head and said, well, let's look at the people with severe disease and try and see if there are any immune deficiencies in that group. So it's just asking the question in a different way. This is a hugely ambitious effort that could have come up completely empty-handed. They were brave to take this on, and they literally worked day and night to pull this off. And I'm pleased to share with you some of the data that was just published in Science. So the patients now are largely Italian patients. Remember, they were at the beginning of the European wave, that early spring wave. So Italy, you might remember, had a very severe outbreak in northern Italy. So these are largely patients from that area. And the first thing that they did was they took blood from the most severe patients, the mild patients, and some control healthy people, and said, do we see anything different in the blood? Do we see anything different? And the answer was yes. About 10% of the people with severe disease had antibodies to type 1 interferon. Now, usually we think of antibodies as being a good thing. They fight infection. But when they're antibodies that are directed to us, that's bad. They're interfering with function. So these antibodies impair the ability of that first alarm wave of type 1 interferons to tell the surrounding cells to put up their gates and protect against virus. So these antibodies are actually bad. They're hampering the ability to set up that early warning system. Interestingly, these antibodies were more common in older men, the demographic at highest risk for severe disease. So that's part one to the story. They found antibodies that interfere with the interferon system. Part two of the story is that in another 5% of the cases with severe disease, they found people who were genetically compromised in producing interferons. So in this little cartoon here, the little spiky looking golf balls, those are meant to represent viruses. And every rectangular box is a gene that regulates the interferon process. The ones in red have long been known to be associated with increased susceptibility to influenza, and the ones in blue have been associated with susceptibility to other viruses. All of these were found to be important for the defense against SARS-CoV-2. Again, implicating this interferon system as being defective, or in the case of antibodies, having something that impedes the ability of the interferon to have the desired effect. They did not find anybody with an antibody deficiency. They did not find anybody with a T-cell defect on a genetic basis. So I think there are some important lessons here. Antibody deficiencies do not seem to be a major risk for severe disease. T-cell defects also do not seem to be a major risk for severe disease. We don't know very much about people in the immediate post-bone marrow transplant period, and we don't know very much about patients with severe combined immune deficiency. What we can say is in this very large study that was done in Italy, New York, and France, that the major risks to be identified in the people with severe disease relate to the interferon system, something that we don't often talk about in this forum because these immune deficiencies were thought to be extraordinarily rare. So I'm going to change gears now and talk about how can we move forward. And I think it is important to recognize that there is going to be forward movement. So first of all, consider your exposure risks. So I have patients who still today will not leave their house even to pick up the mail. And I have other patients who are even much braver than I am. But I think it's useful to recognize that there's a spectrum of risks. Not everything is equal. Playing golf is relatively low risk. You're outdoors, you're not with a lot of people. Going to a bar and drinking is relatively high risk. So there's a gradient of risk, and I think that's worthwhile in trying to figure out where your risk tolerance is and what you're willing to do. I know this group does not need a pep talk about masks, but I will just say it because it is so important. So masks are, they offer some protection to the person wearing the mask, actually not a huge amount, but they do offer some protection. But they're much more important from a public health perspective by blocking the spread of, I'll just say it, spit, and things that come out of your nose. So having the mask is an excellent public health strategy. And you might be interested to know that the first description of masks being used in a public health strategy was the 1918 influenza pandemic in New Jersey. So this is not new information. And I want to just spend a moment talking about life. We were so anxious, all of us, in the spring when this started. I think everything was focused on locking it down, closing the doors. And certainly that was necessary. The virus in my city was running rampant. The hospitals were overflowing. We ran out of antibiotics in some hospitals. And you know, in New York, things were really quite grim with bodies being stored in ice cream trucks. But now that we're in it for the long haul, we have to recognize that we need to manage our lives. And so I'll just remind you that stress is quite bad for the immune system. And so if there's a way to incorporate mindfulness or meditation to try and mitigate that stress, I would encourage you to do that. Exercise is beneficial for the immune system. And then I was talking to a student today about how human beings are social animals. We need each other. I don't know what 2021 is going to look like, but I know that as a species, we need to be with other members of our species. It's just who we are. So with that little transition, I'm going to say a few words about vaccines and the second wave, and then I will close. So vaccines. So many of you have heard some of this. It's been quite a bit in the news about the different phases, but there are 213 different vaccines in development, all at different stages. So some are just thoughts in a test tube, and others are in phase 3 testing, which is right before the FDA will approve it. So all different stages. And I'll just remind you that phase 1 is a small number of people who get it to test safety. Phase 2 is to look at efficacy, and phase 3 is both efficacy and safety. And then there are additional safety analyses that happen even after the vaccine is approved. I know the font will probably be too small to see, but I wanted to make a couple of points here. There are a lot of novel vaccines being developed. So the ones that we are comfortable with, that we have mostly had, are inactivated viruses. So the flu shot is an example of an inactivated virus, live viral attenuated, like the MMR vaccine, and protein-based, like the Prevnar vaccine. So those are vaccines that are out and about being used every day. Those are being developed for COVID-19. But interestingly, the front runners are novel platforms like an RNA vaccine, a DNA vaccine, and the ones that are farthest along are vaccines that are based on another virus. So the adenovirus is a common cold virus, and they engineer it so it stimulates an immune response to SARS-CoV-2. So you don't really have to know what's in the pie just to recognize that there's a wealth of different approaches, and surely some of them will be more effective than others. So the front runner. So I took this off just about 2 weeks ago to give you a sense. So you know that the US government, as well as Australia and many other countries, have put forward quite a bit of money to help support the development of new vaccines. There are some that are farther along than others. The reason I put this slide together was not to say, yay, it's coming next week, but to point out on the right-hand side all of the different types of vaccines that represent the front runners. Among those, and of interest to this audience, is that all but one, the one at the bottom, are inactive either protein or viral products or nucleic acids. So there's only one live viral vaccine that's even remotely considered to be a front runner, which is good news because we don't usually give live viral vaccines to people that are immune deficient. Now, you might be interested to know that there are actually 3 vaccines that are already being used. There are 2 in China and 1 in Russia. They have had less testing than what we would do in the US to get FDA approval, but these vaccines are out there, they are being used, and I imagine they will have information on efficacy before we do. And then this is the second one in China. It is said to be being used for the military, but I couldn't find any information on how many doses had been given. Now, those of you that have been eagerly following the vaccine information and the news stories, you will know that 2 vaccine trials that were quite far along have been put on pause. This is actually fairly common for a drug trial or a vaccine trial. Once there's an adverse event, the trial stops and they go and check all of the records and make sure that there was no one else with something that looked similar that they might not have attributed in the same way. Interestingly, both of these are adenovirus based, and whether that's relevant or just happenstance, no one knows yet. And we don't know what the adverse event was with the Johnson & Johnson vaccine. Well, I don't usually talk about money. I'm not a money person, but I think it's worth recognizing the big investment that has been put forth. So the USA has provided $11 billion in the Warp Speed program, which was designed to stimulate and spur on vaccine development. That money has gone to 7 companies, and it includes $2.5 billion for vials and syringes, which might not be obvious, but to ramp up a vaccine to this level requires a lot of infrastructure. And so the vials and syringes were a big part of it. Now, $11 billion, that's, again, I'm not a money person. I'm not that kind of, I'm not wired that way, but $11 billion I can appreciate is a lot of money. And I think we're all grateful that that money has been invested in such an important public health effort. But I will say it pales in comparison to the CARES Act. So it was $3 trillion for the first CARES Act and roughly $2 trillion for whatever the next CARES Act gets called. So it is a lot of money, and I don't mean to sniff at it or seem unappreciative, but I did want to put it in perspective. Well, how will it be provided? This is of interest to people on this webinar. There are some front runners that require storage in frozen condition. That's going to be hard for places like CVS and Walgreens to pull off, but almost all the rest require refrigeration, which is well within the capabilities of a local pharmacy. And it has not been settled who will get it first. Every model uses Tier 1A as healthcare workers, and that's estimated to be about 20 million people. Tier 1B are other essential workers, thankfully including grocery stores and first responders. And the age limit for Tier 1B has varied. I've seen both 60 and 65. I don't think it's been settled yet. But here's where the rubber meets the road. Tier 2 is for vulnerable people. Now, immune deficient people will surely be in here, but whether we're at the top of the list or the bottom of the list, no one knows. That committee has not been constituted yet to make those decisions. Until then, what about schools? So a lot of talk about kids being asymptomatic spreaders. There was a beautiful study to come out of Spain where they did really good contact tracing, and the kids were the index case, meaning the kids gave it to adults very infrequently. Almost all of the kids that were infected from an adult, not another child, and adult to adult transmission was much, much, much more common than child to adult transmission. In addition, the schools in New York opened in the early fall, and there has not yet been an outbreak. And here I'm speaking of little kids' schools. I'm not talking about colleges where there have been a lot of outbreaks, but those are adults, not kids. Well, what about the second wave? So I gave the good news. The vaccines are coming. They seem to be working. Here's the bad news. So the second wave is coming. These are graphs of Europe. So I just picked 4 countries, and you can see that there are various combinations of a big first wave and a second wave, or maybe a little first wave and a big second wave. I do think there's a message there. This is now the USA. And so this was actually taken a couple of weeks ago. It's much more weighted to the center of the country this week than it was a couple of weeks ago. But here's a point I want to make. So this bottom graph shows the huge first wave that New York City had in the spring. They have not had a big second wave because everyone remembers it. It was a tragedy in New York City with people dying, friends dying, people being buried in shallow trenches. I mean, it was a powerful moment in New York. And so people have been mindful of that and very conscientious. The upper graph is Arkansas. So they didn't have a wave in the spring. They didn't really understand the importance, and they didn't have the same urgency that New York did. So they've had a relatively and I'm not picking on Arkansas. I could have picked any state almost from the middle of the country, but they've had a relatively continuous upswing. So in summary, be patient, be safe. There are risks to people living with PI, but the typical PIs and the people that are likely on this webinar may not have risks related to their immune deficiency. They could have other risks, age, they could have lung disease. It seems like immunologically, the main risks are related to defects in type 1 interferon pathway. The vaccines are coming, I promise. I don't know if one will be better than another. They all seem to work at least somewhat. And one thing to think about is that for people where the vaccine is not going to work, there are antibodies for passive immunity and development. So these were developed not for us on this webinar. They were developed as treatment. They haven't really been outlandishly effective, but now people are looking at them as a way to protect people who either can't get the vaccine or for whom the vaccine is ineffective. So Regeneron has an antibody cocktail. Eli Lilly has an antibody, and AstraZeneca, I think, has another one. So these antibodies are out there, and they could perhaps be given over the winter months, just like antibodies to RSV are given to little kids who are vulnerable. And then I'll just end by saying it's really important to know your community prevalence in the moment. You want to know what the new cases are, not what happened 3 months ago. So I'm giving you 2 websites here. They're both searchable in different ways. They both require a little bit of finesse, but they're pretty easy to navigate. Because I think making these risk assessments that we all need to do now need to be done with the knowledge of what's in your community. I happily send kids to school in communities where there's no rising cases, but I'm a little nervous about it in communities that have a very high case rate. So I'm going to stop by reminding you that I'm around to answer questions, and you can use the chat box. And I also want to say thank you to IDF for inviting me to be a part of the National Summit, which in this newly imagined format, I think is capable of engaging us in different ways. I know people are feeling the lack of the in-person meetings, but I feel like we can connect in some new ways. So thanks to IDF for pulling off this small miracle and for inviting me. So I'm going to stop, and I think Ashley is going to help with the Q&A session.
I am, and thank you so much, Dr. Sullivan, for your presentation. It is always a pleasure having you join us and be here for our community. We have already received quite a few questions. Thank you to everyone. As Dr. Sullivan said, please continue to send those in. And one of the first questions that I'd like to ask you is in regards to the risk associated with contracting COVID-19. So one of our audience members would like to know if cancer increases one's risk for COVID-19, or is the risk increased only for people currently undergoing treatment?
Yeah, that's a great question. So the first papers to come out said that cancer wasn't a risk, which was peculiar because it's a risk for most infections. But like everything with COVID-19, we were just accepting that it was topsy-turvy. So the more recent data to come out, which is a national registry for people with cancer, showed that the risk was quite modest for cancer. It was increased for people with progressive disease. Chemotherapy, standard chemotherapy on its own did not seem to be a risk for severe disease. So the story about risks associated with cancer has evolved over time as people collected a little bit more granular data.
Thank you, Dr. Sullivan. For those with kidney disease, does risk also increase for those who have had post-transplant surgery?
Yeah, another great and sophisticated question. So in the immediate post-transplant period, there is an increased risk of severe disease. I can't remember the exact time point where it normalizes, but I think it's about at the 6-month level.
Thank you. And the next question that I have for you, can you discuss efforts to develop monoclonal antibodies, and if safe, effective, and approved, if this is likely to become available to supplement IgG therapy for the PI community?
Yeah, I tried to allude to that right at the end. So the monoclonal antibodies, or the antibody cocktails, were developed as a treatment approach, and they haven't so far demonstrated much efficacy. And those companies are now trying to turn and ask, could it be tested as a preventive strategy? So it's quite a switch, and they haven't Actually, one of them, not Regeneron, but one of them has started a trial to protect healthcare workers, but no data has been released yet. I do think that that approach has a great deal of promise for our community. So I'm enthusiastic about following that data. And sidelight, did everyone see the article about antibodies from llamas today? I hope you did. It was like a moment of levity and an otherwise disappointing week. So llamas make weird antibodies that are very different than human antibodies or cow antibodies or pig antibodies. And these antibodies are actually super strong at binding COVID. And so they're trying to make a llama antibody cocktail that would be used as a preventive strategy.
Thank you, Dr. Sullivan. Another attendee has asked, is there still a risk of contracting COVID-19 from surfaces like groceries or just aerosols?
Yeah, boy, has the messaging on that changed over time, right? It's been a little confusing. So yes, you can get COVID-19 from surfaces, but hard surfaces where the liquids persist are much more of a risk than paper or cloth. So I know some people that change their clothes the instant they come in the house. Clothing, paper bags, that's not where the big risk is. It's more like hard surfaces that are metal, like a doorknob or glass, where again, I apologize for having to talk about spit, but spit or any kind of sneeze material, mucus, would live on it and stay moist for a period of time. So, so yes, surfaces are a risk. I think we have downgraded the magnitude of that risk over time, but yes, you absolutely can get it. And the other question was aerosols versus respiratory droplets. And that has been so politicized, my goodness. So I think everyone would agree that the main mechanism of transmission is respiratory droplets, which is sort of a fancy way of saying the stuff in the air that you can see. And aerosols are much finer particles. So aerosols absolutely can do it, but in everyday life, walking around talking to people, it's probably much less important. It's probably much more of an issue in a medical setting where you're, where you're actually looking into someone's throat and that virus could be airborne. So the messaging on that has definitely changed quite a bit. The virus is in both respiratory droplets and aerosols, but in our everyday lives, it's the respiratory droplets that are the primary source of transmission.
Thank you, Dr. Sullivan. Our next question, is there any information to indicate whether IVIG or sub-Q increases the potential of getting a severe case of COVID?
So it's thought to be completely bland. It's neither protective nor does it increase severity. The virus is essentially invisible to the IVIG or the sub-Q product right now. Now, the hope is that 5 years from now, when either a lot of people are vaccinated or they've had wild type disease, that there will be antibodies in the community that will be in the immunoglobulin products. But at the moment, the products are neither helpful nor hurtful. With respect to COVID-19, sorry, let me be completely clear. They're helpful in general life, but in terms of COVID-19, they're neither helpful nor hurtful.
Thank you, Dr. Sullivan. As you can imagine, we've also gotten a few questions about antibodies in IVIG. Do you know whether or not there will be antibodies in IVIG in the future? And if so, when we might know if they are in there?
Yeah, I would think that we would see a gradual increase over the next few years. There's sort of a lag of about a year, year and a half from the time the blood is drawn from the donors till it shows up in a vial. So it certainly isn't going to be right away. I think that we will see a gradual rise in antibody levels. Will it be enough that on its own it will be protective? I don't think anyone wants to hazard a guess yet.
In terms of risk of a second infection, do we know if a person with a compromised immune system, such as those with PI, are more susceptible to a second infection? And what are the complications that might arise from a severe second infection?
There have only been a handful of second infections reported. I think you've probably seen some of them in the news. They've all been people that were otherwise healthy, and it's of the few cases that have been reported, and it's literally a handful. It's gone both ways, where someone had a mild course to start, a severe course the second time, or a severe course the first time, a mild case the second time. So I think it's much too soon to say. Will immune deficient people be more at risk for getting it a second time? I think people who have trouble making antibody will be more at risk for getting it a second time, but I don't know that that necessarily means it will be more severe the second time. I don't know.
Thank you, Dr. Sullivan. Our next question. Is there a potential risk with DNA or RNA vaccines as a result of introducing alien genetic material into the body?
Yeah, that's really been what has held these platforms back so far. There have been efforts to make RNA and DNA vaccines for influenza, for warts. So there have been efforts to develop these platforms for diseases before COVID-19, but the level of concern always held people back. The push to get a vaccine out quickly sort of re-energized these technologies because they're just technically a lot easier than the traditional vaccine development. They do work, so they have in other conditions. So years ago, when they were trying to make an RNA vaccine for flu, they could demonstrate that it worked. So I don't have reservations about it in terms of efficacy. Your question about how weird is it to put another nucleic acid inside your body, they haven't, in hundreds and hundreds of animal tests, they haven't seen cancer, they haven't seen that the material even persists or mutates. So I think it's safe, but I guess anytime there's a new technology, one wonders what we're going to think 20 years from now, and I can't know that.
As you know, Dr. Sullivan, the holidays are coming. It's a time when we usually spend time with our loved ones. We have a few members in our community who have told us that they have grandchildren that they haven't seen, and they are curious whether or not they need to continue distancing. You mentioned that it is rare to get COVID from a child, who one of our audience members noted, and they wanted to know what that means in terms of the holidays coming up.
Yeah, boy, I think everyone's going to have to test their risk tolerance with the holidays. So I would say for me, when patients call me, the first thing I ask is, what's the case rate in your neighborhood, in your city? Because that would be my single biggest determinant. If I lived in a part of the country that essentially had no COVID-19 the week before Thanksgiving, I would probably feel okay about having a small family gathering. If I was in a city that had a very high caseload, then I would probably say, no, if we can't picnic outdoors or do something where we can stay socially distanced, I wouldn't do it. But everyone's risk tolerance is going to be different.
Thank you. Thank you so much for that, Dr. Sullivan. Another audience member has asked if they are on antibiotics, such as prophylaxis for PI, will that provide any level of protection against COVID-19?
Yeah, great question. That's a really common question. And the answer is, as best as we can tell, no. You probably remember at the beginning in the spring, there were people that were advocating the administration of azithromycin to treat COVID-19. That hasn't really panned out. And so at this moment, the feeling is that there's no standard antibiotic that is effective in either the prevention or the treatment of COVID-19.
Thank you, Dr. Sullivan. What kind of long-term issues or post-COVID-19 syndromes are being seen and the PI community may be more at risk for?
I essentially shared with you all of the data on acute COVID-19. So there's the international consortium of 94 patients, the New York series of 16, and then there are 3 patients from Italy that have been reported. So I've really shared with you all the data. There is one case. So let me just back up. So the post-COVID experience sort of comes in two flavors. So there's the very prolonged recovery that has a lot of fatigue and lingering respiratory symptoms that they sometimes call them the long haulers. So there's that just super slow recovery. And then in kids, there's this phenomenon called MIS-C, where they essentially have cleared their virus, and then they come down with this huge inflammatory process that is terrifying to see. However many times I see it, I can't get used to it. So those are different things. Are immune deficient patients at risk for sort of the long haul syndrome, the people that take a really long time to get back to their baseline? I don't think anyone knows yet. Charlotte Cunningham-Rundles has said that she thinks that the immune deficient patients do take longer to get better. In terms of this big inflammatory response that's more typical for kids, but also seen in adults, there's been one immune deficient patient reported who has done that. Interestingly, it was someone who had a defect in the interferon pathway. And so again, it all sort of seems to come back to this very careful regulation of interferons early in the course of disease. So not much data out there. I wouldn't want to over interpret what data there is, but so far there doesn't seem to be a big signal of any late-term sequelae in immune deficient patients.
Thank you. Is there a test for patients with PI to see how their interferon levels are and to see if they have a genetic interferon deficiency?
So the testing so far for interferon defects is largely genetic, and so you would get something called whole exome sequencing. It's quite expensive. It ranges from $1,000 to about $12,000. And so, you know, it could be done, but typically it's done on people for whom there is already an idea that they have this problem because it's so expensive to do.
How important is it going to be for the PI community to get the flu vaccine with COVID-19 currently taking place?
You know, I was just so pleased to read that they have distributed more flu shots already this year than they did all season last year. I think people are getting the message. I think it's really important. We have no idea what it would mean to get influenza and COVID-19 at the same time. It sounds terrifying, right? And we know that in the intensive care unit, so in a non-COVID year, so years ago, if you run around an intensive care unit and take viral swabs from people, about 10% will be infected with two viruses at the same time. So we do have this thought that having two viruses at the same time is bad, and it makes sense. It's perfectly rational. And so the concept of someone might getting flu and COVID-19 at the same time is pretty terrifying. So I was really pleased to see that in the community, people are taking the advice to get their flu shot. I think it is smart. Plus, I don't want to be, I don't know about other people on this webinar, but I don't want to be around people that are coughing and sneezing because I can't tell if they have COVID or flu or some other cold virus. And so it even makes me nervous when there are people around me who say, oh no, it's just allergies. I can't know that. So I think there's lots of public health reasons to get the flu shot. And boy, am I glad that people are taking that message.
Absolutely agree. Thank you, Dr. Sullivan. Is it possible to have COVID-19 and present with GI symptoms without the respiratory symptoms?
Yes, it does happen a little bit more often in kids, but has been described in adults as well. So the receptor for the virus lives in the GI tract and the respiratory tract. So both sites are actively infected usually, but some people have more GI symptoms, some people have more lung.
Thank you. And can you briefly touch upon the significance of passive immunity with COVID-19 and how that would, if it's going to help patients at all?
Yeah, thank you for asking that question. I was feeling like I gave that topic a bit of short shrift. in part because it's unclear what the pharmaceutical plans are. So this is now my opinion, not fact. For this respiratory infection called RSV, for kids that are deemed at very high risk of severe disease, what we do is starting in November or December, we give them a monthly injection of an antibody to RSV that provides them protection. So the way it works with RSV is we give usually 4 or 5 monthly injections through the winter months, and it's designed to prevent infection. You could imagine a very similar model for COVID-19. Antibodies haven't been conclusively demonstrated, but are thought to be the main mechanism that prevents infection. So if you have antibodies to SARS-CoV-2 in high amounts, you won't get infected if someone coughs on you with the virus. And so the idea would be immune deficient people who either can't get the vaccine or the vaccine won't be effective would get these injections during the high risk time frame, and that would provide them protection. And so that's called passive immunity.
Thank you, Dr. Sullivan. And our final question for you: when will PI patients know if it is safe for them to get the vaccine that comes out for COVID-19? Are they going to run any tests for immune deficient patients? And where can individuals in the community find reliable information about the vaccine? A lot of questions there, but.
Yeah, it's a lot to unpack, but I will say, I think it's very unlikely that a live viral vaccine will be anywhere in the first wave administered in the US. So anything other than a live viral vaccine, which is to say any of the front runners, I would feel very comfortable giving to my patients. Now, you'll want to have a conversation with your own immunologist, but I personally plan on offering the vaccine to all of my immune deficient patients. When we give a vaccine, the goal of the vaccine is to drive the production of antibodies. For someone with CVID, for someone with X-linked A gamma globulinemia, they might not get much antibody out of the vaccine. But there's another part that we don't often talk about, and that is the T cell response. And at least in animals, you can show that if you get a little bit of a T cell response to the vaccine, that won't prevent infection, but it mitigates the severity of infection. So again, this is just me, but I would certainly encourage all of my immune deficient patients to get the vaccine when it's available, with the exception of the live viral vaccine, which I think is not likely to be in the first wave of vaccines that are administered.
Thank you. Thank you so much, Dr. Sullivan, again, for joining us here today. We truly appreciate your time. Thank you to our audience for asking all of those questions. We did receive quite a few, and thank you. At this time, we are now at the end of our first keynote session. We will continue programming tomorrow morning for the entire community beginning at 11 a.m. So please make sure that you join us. And for those young adults in our audience, ages 18 to 35, we are having a special meet and greet after this session in the IDF Lounge. Please feel free to join us. It is a great opportunity to meet others, interact with the community, and get to know each other. Dr. Sullivan, always a pleasure. Thank you.
Ashley, thank you so much. And thanks again to IDF.
Thank you. Have a wonderful evening, everyone. Thank you.